So we wanted to very quickly summarize that the case controls we feel like have been adequate to get us from a 2B to a 2A in IARC, and that we would hope to someday achieve IARC-1, knowing about additional tumor types such as parotid, testicular, breast, and hematopoietic that have been presented by various people. We wanted to turn over a lot of the mechanistic information to Fiorella and her group and Linda's group, who's not here. And I wanted to incorporate Yael's comment that research has been performed on technologies that have been used in the past, but thinking that actual research might be a good idea to do before things are actually used in the future is a good thing. And then we wanted to focus on what could be done and should be done immediately, and immediately we wanted to spend some time focusing on the non-cancer outcomes and dovetailing with the other groups, thinking about the implications of decreased screen time and all the benefits of decreased screen time. So specifically, Hagai wanted to get more information, standardization, improve exposure assessment methodology for epidemiologic studies, interdisciplinary collaboration between exposure experts and epidemiology, and I think some of that was said also by the policy group. And then we were talking about what studies could and should be done immediately, and in the immediately, we thought that we had some good studies that were actually done in India that we could replicate in various places in Israel and the United States.
I want to thank Iris and Hagai for summarizing. I just want to add a couple of things. I want to emphasize one thing first. What Iris started off saying, that we felt that the epidemiology studies already performed enable us to say radio frequency fields are a probable human carcinogen. In terms of IARC, that's incredibly important, because with the animal studies we've got and with the mechanistic studies we've heard something about, that would put radio frequency fields in category 1. That's the first point. The second point is that we did obtain information from a number of people. Unfortunately, Hagai, you couldn't be here yesterday, but it became clear there's a lot of exposure going on and it's increasing. We have the issue in the Israeli military with exposure to radar and unusual cancers in terms of what we thought were likely to be increased by radio frequency fields turning up in greater proportion. Hematolymphatic cancers and testicular cancers, so we have to be aware of that. Then there is the question of what studies can be done further. We agreed that case control studies give us the opportunity to do detailed exposure assessment, which cohort studies cannot, unless we capitalize on existing cohort studies. All over the world, there are existing cohort studies primarily performed to collect biological specimens and address the issue of the associations of cancer or the relationship of cancer with genetics. It would not be difficult to develop well-constructed, relatively short questionnaires that could be addressed to the people who already participate in these cohorts and obtain additional information that could subsequently be analyzed in a nested case control approach,
Right.
with using the biological specimens there to look at issues such as genetic susceptibility and possibly other biomarkers. And the other thing I think is important that came up yesterday and is very critical is we had some excellent presentations on electrohypersensitivity. And it's very clear at least to me, that this is a syndrome that exists. But it's also clear that as yet we haven't developed a clear definition of what we're talking about that everybody understands. So that's work that is necessary to be done.
In the end, what the most important thing is the values, as said by Ellie, the values, and to put humans in the center, to the health of the public or the health of the people in the center, and not the interest of the industry, not the money, and not the technology. Because for some of the technologies, the standards are set by technological aspects. For example, for the Wi-Fi, it's by that it will not affect each other. There will be strong radiation, strong connection, but not set by the health of the people. So with all the debate between us about the epidemiology, which I totally agree with you on that, but I'm saying besides that we should the very least make sure that the health of the people is in the middle of the debate and not other considerations.